Okay, good evening, everyone. Good evening, scholars. You're welcome to your second mentoring session for 2026. We are very pleased to have you here, and we are also honored to have uh, our guest mentor, Professor KB Badmos, with us. We hope today's session will be insightful and engaging for every one of us. So before we begin, just a few reminders, like we try to do every session for new people joining us. Please keep your microphones muted unless you need to speak. The attendance form will be shared in the chat as the session progresses. Ensure you fill it. Also, feel free to use the chat to drop your questions or comments as the session progresses. Okay. So today's session is going to be on research, evidence, and health education. I know that some of you may have looked at the topic and said, this is for final year students, researchers, or postgraduates, but it really is not. The topic is relevant to every single one of you, regardless of your level or discipline. As students and future healthcare professionals, it's important to not only learn information, you also need to understand where the information comes from, how reliable it is, and how to communicate it responsibly to others. And that's why we're pleased to have Professor Badmos guide us through this discussion today. Okay, it is now my pleasure to introduce our guest mentor for today, Professor KB Badmos, who is a professor of anatomic and molecular pathology at the College of Medicine, University of Lagos. He previously mentored some of his scholars in 2023 on Introduction to Research, and we are delighted to have him back with us today. To formally introduce him, I would like to invite Kudus Agbolanwa Ibrahim, a 400-level pharmacy student at the University of Ibadan and a FAJIM scholar, to kindly please read Professor Badmos's biography. Is Kudus on the call?
Yes, ma'am.
Okay, great. Can go ahead now. Thank you.
Good evening, our distinguished lecturer, Professor Fatima Abdul Karim, Ms. Mariam, my fellow scholars, and everyone present. It is my honor to read the bio of our guest lecturer for today's mentoring session, Professor KB Badmos. Badmos Kabir Bolarinwa is a professor in the Department of Anatomic and Molecular Pathology, College of Medicine, University of Lagos, and an honorary consultant at Lagos University Teaching Hospital. He is an accomplished academic, researcher, and histopathologist with specialist expertise in gastrointestinal and liver pathology, as well as cytopathology. Prof. Badmos obtained his MBBS degree from University of Ibadan in 1998 and completed his residency training in pathology at Obafemi Awolowo University Teaching Hospitals Complex. He earned specialist certification in histopathology from the National Postgraduate Medical College of Nigeria in 2006. He also holds an MD degree and is a fellow of the Medical College in Pathology. With over a decade of professional experience in pathology practice and research, Prof. Badmos has contributed significantly to histopathology research, particularly in gastrointestinal pathology and cancer studies. He has authored more than 40 publications in national and international peer-reviewed journals and has successfully managed several research grants, including grants from the University of Lagos Central Research Committee. Beyond research, he is deeply committed to mentorship and postgraduate medical education, having supervised and mentored numerous postgraduate doctors, many of whom now serve as university lecturers and hospital consultants. Prof. Badmos is an active member of several professional bodies, including the Nigerian Medical Association, Medical and Dental Consultants Association of Nigeria, College of Nigerian Pathologists, Society for Gastroenterology and Hepatology in Nigeria, African Organization for Research and Training in Cancer, and both the West African and British divisions of the International Academy of Pathology. His recent research publications have focused on colorectal carcinoma, immunohistochemistry, cervical cancer screening, and molecular pathology, reflecting his continued contributions to advancing cancer cancer diagnosis and pathology research in Nigeria and beyond. Please kindly join in welcoming our professor, Professor Kabir Bolarunwa Badmos. Thank you.
Thank you very much, Kudos. Professor Badmos, thank you once again for joining us. The floor is yours, sir.
All right. Good evening, everyone. And I'm very sorry for the delay. I've been having running battles with my laptop since the afternoon, trying to get the audio sorted. I don't know what happened. I can't hear anything and I can't even make any audible speech. But be that as it may, time is fast spent. So we start now. I want to thank the FAJIM for inviting me in to give this lecture. Research evidence and health education. As an healthcare giver as well as an health educator in the University of Lagos, it's imperative that our decision in giving care to patients must be guided. And this has not to do with speculation or what I believe or what some of us believe in. It must be rooted in what has been scientifically proven locally and compared with what other people in other parts of the world are found to be useful in getting optimal care for their patients. Now, it's a two-pronged approach when you talk of health education. You have the community and you also have the schools where you are training young practitioners in terms of what they need to learn about health education. So we move to the first slide. WHO defined health in 1948 as a state of complete physical, social, and mental well-being, and not just the absence of disease or infirmity. And this is what we were taught as medical students over 2 decades ago. And then I believe nothing has changed from this definition. And the concept of health, as a result, has been considered less as an abstract state and more as a means to an end, which can be expressed in functional terms as a resource, which permits people to lead an individually, socially, and economically productive life. Next slide shows the interface between the mental, physical, and social activities that brings about a whole health or a whole well-being of an individual. People doing what they enjoy doing best, having good social relationship, feeling control over one's life and living. And this has to do with personal, community, and the larger society as we all know it. If, for instance, individually, you are taking care of your health, but in the community, there are challenges of industrial pollution. There's limit to what you can do, except you communicate these events to government so that they can take care of the pollution. Otherwise, everybody in that community in the long run will be subject to disease emanating from such pollution. So it's an integrative kind of thing between what one personally can do and what can happen in the environment. Next slide. And health education has been in many over the years, but I pick that of Green et al., who in an earlier work concluded that health education was limited to conscious health-directed behavior, and it was most effective when people were clearly oriented to solve a discrete and immediate behavioral or health problem of importance to them. However, there were several other definitions, but controversy emerged in literatures among health providers as to where the focus should be. Is it individual versus social responsibility for health, facilitate individual behavior change versus broader institutional and social change, behavioral versus ecological strategies, healthy people versus healthy cities and healthy policies, blaming the victims versus blaming the manufacturers of illness. These are things that proper from the definition given by Green and some other workers in this field. So now WHO synthesizes what has been defined by earlier researchers and aggregate it together as the fact that health education is consciously constructed opportunities for learning involving some form of communication designed to improve health literacy, including improving knowledge. Is not just as knowledge only, and developing life skills which are conducive to individual and community health. This definition of what health education entails is actually what is being integrated into medical school curriculum, so that those who are health practitioners that are going to be interfacing with the communities, implementing health policies that are being formulated by government, they need to know about what health education is all about, right from the time they are in medical school, in nursing school, as a physiotherapist. Indeed, all health caregivers need to be aware of what health education is early on in their career. So the WHO document describes health education as not limited to the dissemination of health-related information, but also fostering the motivation, skills, and confidence necessary to take action to improve health, as well as the communication of information concerning the underlying social, economic, and environmental conditions impacting on health, as well as individual risk factors, risk behaviors, and use of healthcare system. When we talk of risk factors, there are many perspectives that people lay on in terms of what causes an health problem and what are the behavioral reasons why someone acquired an ailment. I give you an instance. Breast cancer, when I was in secondary school, it was attributed to bad omen. Somebody living that is fighting, I mean, there are people that have conflict with their neighbors. And how do they solve the problem? Because I had a particular case of one elderly woman that had breast cancer in my neighborhood. And what they did to solve the problem was to kill a small goat and share the meat among the members living in the community to appease people that are being offended so that the cancer can go. Invariably, the woman died within a year of that progression of the disease due to lack of health education. Is not aware of the risk factors. She's not aware, and the people around her are also ignorant of what can be done to mitigate the disease process. These are challenges that have to be solved by healthcare providers, as well as enlightening the community in terms of those risk factors and modifying their behavior. That is part of what health education is all about. And when there's a disease process, are there ways of treating this different from our own traditional cultural beliefs, so that we can have disease outcomes comparable to people in other parts of the world have similar ailment and disease. People survive 10-year survivor, 15-year survivor, but in our own instance, in many communities, in many local communities, survive not more than 1 year to 2 years because of our cultural beliefs as to many of the ailments that ravages human beings, not only in Nigeria, not only in our society, but all over the world. Next slide. Whereas research evidence refers to the data and findings obtained from research studies and experiments, which are used to support or refute hypotheses, theories, or claims in a particular field of study. And this is synonymous with evidence-based medicine. We talked about research in the last topic. Next slide, I discussed with the FAJIM Scholars. And this is what people do when there are challenges or problems in the society. People involved not only in medicine, in means of transportation, in means of communication. Some people will sit down that have similar ideas and think, okay, what is the burden of this? What problems do we have causing health-related issues in our society? What is the number one? Can we document it? So we look back. How many people are even living in our community? How many people came down? How many people came down or died of disease A? How many people are suffering disease B? That is one means of getting information retrospectively. And then you look at literature. Has any work been done along this line? And if work has been done, has there been any further experimental studies that have looked at treatment options, those who have treatment and those who don't have treatment? What are the outcomes of this treatment? So from the data that we are collecting and from the analysis of data, we have an idea of who are at risk for most of these ailments in our society. Are they males? Are they females? What is the age bracket? Are they the working class? Are they the elderly people? Can we prolong their lives? In the other society, in other parts of the world that have had similar challenges, what has been done for such people? Do we have similar pattern of disease progression compared to them? What have we been using? So these are several research questions that can be tailored towards solving local problems while comparing what we have gotten, subjecting to peer review to know whether in terms of what we have is similar to what others have, or in terms of our treatment modalities, are we doing fairly well okay compared to what people have done in other climes? Or in terms of what is locally available in terms of herbs or drugs that are being used, are they effective compared in terms of disease outcome compared to what is being used in other Western or Eastern part of the world? So it is only through research, not through stories that people have narrated in the past, that this is what our grandfather used to use. So next slide. And that brings us to the issue of evidence to impact framework. And that is actually the core of the discussion, bridging the gap between theory. We know, we've read it, students have been exposed to some discussions about different ailments in different parts of the body that is ravaging the world or ravaging the local communities. What are the behavior of people when this disease really happens? What do people do in our communities? What are the likely behavior of people around those who are sick in our environment? And what are the possible health outcomes based on what people are doing to treat such ailments in our communities? Don't forget that we don't exist in isolation. Even communities in Nigeria, different communities in Nigeria, will not exist outside the framework of whatever is available in the country as a whole, except few individuals that can leave the shore of the country to access it. But the majority of the 220 million people living within the confine or geographical environment of Nigeria are subjected to external impact of whatever is available in terms of policy, in terms of healthcare that's available within Nigeria. Over 90%, we have to make do with what is available. So that takes us to the next slide. What is the ultimate goal? Health education, we must note, is just one of the components of health promotion. It's actually health education, prevention, and then health. There are three components to health promotion, but our focus is about research and health education, research outcome and health education. So health education is about consciously constructed opportunities for learning that are designed to improve health literacy, develop life skill, and foster self-efficacy necessary to take action. So it's just imperative that health education cannot fly on its own. It has to do with some form of literacy. Either people are communicating in their local language. We are a bit unfortunate that we are not using, we can't use any of the local languages in Nigeria to learn. From primary school, our medium of learning has been English, and that cut off quite a large number of our population in terms of whatever we are discussing, we are talking about them. And many people that are educated in with this Western education, they cannot even communicate in their local language any longer effectively. And this discordance results in a large gap in terms of health literacy, the percentage of those who are literate about their health in the society. Even when the health workers are talking, most of the discussions are always in English, on radio, on television. Little opportunity is given to the larger populace that are not educated. And this creates a discord in whereby people get more and wrong alternative information from local sources as to how to manage health, as to interpretation of what health problems really are. Health literacy is the cognitive and social skill determining the motivation and ability of individuals to gain access to, understand, and use information to promote good health. It is critical to individual empowerment. So the foundation to health education has to be a deliberate and conscious effort to increase the literacy level of the entire country. If we are going to be using the Western English medium as means of instruction in Nigeria, so also the larger community has to be carried along. So if this is done, it will be very easy to communicate in the society, in the town, in the cities, many of whom are not really educated or cannot speak English. And both of them dovetail into part of what health promotion is all about, which is the process of enabling people to increase control over and improve their health. It goes beyond individual behavior to address social, institutional, and community change. Next slide. So health education involves building individual capacities, raising their consciousness, motivating them, and building some skills, which when added to the healthy public policies are made by government, creating environmental supports, rules, services, social support incentives. So when you talk about health education, for instance, talking about blood pressure, and you have chance to talk to people in motion markets as a student group or a research team, you go to motion market, just in Odiolowo here. And if you decide, we know that a lot of people have high blood pressure, which is a silent killer, and your mode of communication is English, you can be rest assured that that form of health education planning was wrong from the word go, because you will not achieve anything. Because majority of those who are in those markets, even if they speak English, they do not understand what you are talking about. So you have to communicate in their local language. You must have capacity to communicate in their local language, plan for it, using community mobilizers to have enough body of people in the market, and use a convenient time so that people will not be busy to look for their daily meals, and then majority will be absent when you are trying to impart knowledge on them. That will engender long life so that they can actually make more businesses for longer period. So, but if we're able to communicate with them about blood pressure, possibly in the language they understand, one thing you would have achieved is to raise their consciousness about the silent killer effect of high blood pressure, and then illustrate with examples that will motivate them, and then providing options where they can go to, what they can do, what they can buy to check their blood pressure, the health centers they can go to check their blood pressure. So people can actually, if you demonstrate to them, involve them in how to take the blood pressure, they can be motivated to even purchase this meter and check their blood pressure on their own. Anybody who has high blood pressure can then go out to the health center to seek help. Now, that is where the challenges will not come from environmental support. If there's no well-equipped health center with health workers and the people go there to seek, for instance, we are talking about blood pressure, to seek treatment for blood pressure, they'll be discouraged. Even though they knew that they are aware that they have high blood pressure, you go to the health center nearby you, they refer you to the teaching hospital. You go to the teaching hospital, you spend long hours, you didn't go to shop that day. The next day, you won't see them coming around at all for any form of blood pressure check and treatment. And these are things that are the barriers that have to be broken. The peculiarity differs from one community to another community. And those peculiarities are part of what health education is all about, studying them and breaking those barriers so that whatever you are going to impact or involve the community about, they have to understand it. But the issue of policies in terms of creating environmental support like health centers is actually beyond the capacity of individuals. Sometimes the community can fill the gap where government fails. But sometimes many of the communities do not see it as a communal responsibility to engender a good health center. Now, there are other rules that government can make that can also support good health or blood pressure. These are things that will assist in health promotion ultimately, and also bring about reduction in inequalities and improve health outcomes. Literacy is crucially linked between the individual health capacity and health outcomes. Health literacy is very, very critical to health education. Next slide. The engine of clinical effectiveness. To the left, you have the disconnect. Application of evidence-based practice is observed irregularly at the point of patient contact. And this creates a dangerous dichotomy between the best evidence and actual clinical care. So as a practitioner, as an health practitioner, it's very important that we must update our knowledge and we must follow what is in terms of best practices, what is actually advised. And this will bring about the best in terms of health care for patients that are visiting hospital, for community at large, so that they can also take care of their health, and the health of the entire country will actually be top-notch. But in solution is actually the evidence-based health education, which to the right of the slide, which is the systematic process of finding, appraising, and using qualitative and quantitative research findings as the basis for practice decisions. So we talk about research in the past. So if you are talking of high blood pressure, what is the best means of tackling this? We all know that checking blood pressure at a visit by a patient does not mean that you just start giving medication to the patient. You have to check twice. And then if it's not something that is life-threatening, you give patient another appointment while he's undergoing some medical tests to check whether that is spurious or is confirmed. And once it's confirmed, there are many things that you do. It's not only drug, it's multidimensional. So, and this has been shown to be of great help. Diet, people reducing salt intake, people reducing the number of stress that they go through, people increasing if they don't have adequate night sleep, they should ensure that they have adequate sleep, exercise, the diet that they take. All these are things that, apart from the medication, can actually enhance the health of the individual by ensuring that even with minimal medication, the patient can get well and then the disease progression can be reduced. And this has been shown in several research studies, both longitudinal studies or retrospective studies, looking at what people have been eating, what how many form of exercise that people do per day in a week, what kind of work do they do, what is their social habit in terms of smoking, drinking, and these are things that have been published in several literatures that have been found that, okay, those who are smoking, it's not only that smoking causes cancer, it also makes the issue of high blood pressure it makes them to be at risk for high blood pressure. People that are sedentary, that don't even move around at all, those who are at risk of obesity, those whose food are purely fatty, they don't take vegetables. We all know that all these things have been published by following up individuals for a long time and also taking their samples when they visit clinic, subjecting it to laboratory tests, and they find out that most of these things, there are many things in the environment that can be modified to control the blood pressure. This is evidence-based, and these are things that students have to be, healthcare have to be exposed to, so that early on in their education, it's not just telling them that, okay, hypertension, these are things that cause hypertension. They have to be exposed to it early on in their career, so that once they know that, okay, these are people that have hypertension, they know that, okay, these are the things that predispose: high salt intake predispose to hypertension, high fatty meat predispose to hypertension, low exercise predispose to hypertension, and they are able to sync these findings from literature with whatever they are taught in the classroom. It will be ingrained in their memory, such that when they become practitioners as well, it's something that become core of their practice, and they can actually reach out to many people also as well early on their practice in their career to solve that problem of high blood pressure. So the goal is by ensuring 90% of clinical decisions reflect the best available evidence. We guarantee optimal patient outcome. Note that the end point is optimal patient outcomes. So it's a dual thing. So next slide. So this is the 5 A's of the methodology of health education and research. When you look at assess, evaluate the outcomes of intervention and identify new gaps, feed it back into the ask phase. So when you ask, you formulate clinical practice and question using the PICO process. And then do from this, either use questionnaire based in those with the rational method. That is what's called rational method, which is actually what the majority of researchers, instrument that majority of researchers normally adopt, KBP, knowledge, attitude, behavior, and practices. And this will help to acquire, identify, retrieve evidence-based, pre-processed sources of information, and then you evaluate the validity and relevance of the evidence that have been gotten, and then integrate this evidence with patient values and clinical expertise to make shared decisions. This involves the process of looking at deploying research to the communities through several instruments. We know that many times we administer questionnaire. Some of the research projects that we have been involved in, some of them involved using questionnaire to ask people about their perception to some ailments. For instance, we did some studies. There is some studies past and present ongoing on colorectal carcinoma. A lot of questions were being asked from the people that have the disease or those who came about to the hospital with something that is not relevant to colorectal carcinoma. And these are being synthesized to look at what is it in the behavior or in the perception of people that might have been responsible for delay in presenting to the hospital. What is it that they've been doing in terms of their dietary habit, in terms of looking for cure, that could have been responsible in fast-tracking the ongoing process of the disease or mitigate against the progression of the disease? And what are the practices, what are the kind of treatment that people have sought before getting to the hospital? So these are things that questionnaire actually is very easy to administer to patients. And actually many studies involve the usage of questionnaire. When you have them, it may be cross-sectional study. I mean, those who have disease, those who don't have disease, you administer questionnaire to them. You want to compare the two groups. Okay, those who have the problem, those who have problem, administer questionnaire to them and see what is there anything in group A that group B is not doing, or is there anything in group A and group B that they are doing together, so that you can decipher what could have been responsible, what group A has and group B does not have. That's one form. Or it could be a longitudinal study that you study people over time. One of them is the cardiovascular risk assessment in US, whereby they studied people for close to 90 years or 70 years. The study has been ongoing now for over 70 or 80 or 90 years, thereabout. whereby people were studied from right from their young age till when they grow very old, and see those who are going to develop cardiovascular risk. At what age do they develop that? What kind of cardiovascular risk do they develop? Is requires a lot of funding. There's no research that is going to be carried out without adequately sitting down to design how much time, how much fund, what is the cost implication of what you are going to need to conduct an effective research. So, and once research is conducted, the information will be subjected by those who have vast experience in data analysis, the statistician. They have to actually be carried along from the word go, so that when you are designing whatever you want to administer, any instrument you want to administer, either it's going to be a longitudinal study, it's going to be an experimental study, or it's going to be a retrospective, anything you want to design, you have to carry a statistician along from the word go. This is what I want to study. Then you design the data entry that you want to enter, how much, what kind of data you want to enter. Because once you start to enter the data, it makes it easy to analyze. Otherwise, when you enter the data on your own and you now pass it to statistician, the data may be useless, because you might have missed out some few things that are necessary, or the people that are being interrogated may feel that, okay, this is personal. For instance, there was a study on HPV I was involved in, and we discovered that along the line, when when the data was being elicited or taken from the people, there are some things that questions like, which is actually is anonymous. The data something form were anonymized. There's no identifier on the. We knew the set of people were interrogating, and the forms were anonymized. But we're asking questions like, how many partners have you had in your lifetime, which is part of what can predispose to HPV. And this aspect, over 60% of people that were interrogated did not answer, which is very, very important, because the time we wanted to now analyze the data, we now discovered that those who were trained to administer the questionnaire didn't get back on time, that they're having challenges asking this question from people that were supposed, the group of people, cohort, that were supposed to be interrogated. And that was a dark spot in that data that was generated. Very, very important to carry statistician along when you want to do any form of research to solve a particular problem in the community. Next slide. So in health education, based on a lot of research outcome for different diseases we want to study in the society, be it diabetes mellitus, which is also very, very, particularly type 2 diabetes mellitus is a major problem in the societies, or things like infections like Lassa fever that have been in Nigeria since 1950s, and the number is not going down. Most states are being affected. So you must have evidence to map out what part of the country is, not just that people are dying. You want to know what is killing them. Who are those that are dying? Is it people in the rural area, the farmers, or is it people in the urban area, or is it in a particular locality? We know the belts because of research. Edo State, Benue, Plateau Axis, Ebonyi. These are the hot spots. You can have sporadic cases from in other parts of the country when, because of the easy traveling, people can travel overnight from one place to another place and bring the disease, then 2-3 people in that area, because they are not aware of what is necessary to stay away if somebody is infected, and they can also actually catch the infection, and then we start to map in terms of a risk of infection to control it. So there are many models that are being adopted in health education to reach out to the larger community, to pass information to people based on evidence-based practice, which requires a deep understanding of targeted health behavior of people and environmental content. So you have to understand what is the thinking of the community in a particular locality. What are they? Because if you bring something today, you bring a CT scan to my village and you ask them to enter the CT scan, knowing fully well that the CT scan MRI will generate a lot of noise. You won't see anybody coming forward for any CT scan because you chain them down. They say, you want to kill me? So you have to really understand what is the behavior of people in this locality. And you have to come down to their level to bring them up to your own level of knowledge by educating them. And there are different models that have been adopted. But 3 out of about 9 models is what I'm just going to expatiate on. The rational model is what I mentioned. The knowledge, attitude, belief, and practices is one of the most commonest method of eliciting data in our society. That belongs to the rational model. Most places, is one of the easiest means of getting data in the society about what people are doing. So when you have that data, then intervention can be based on that. Well, many publications actually based on KABP, but there are other models that are being used in several countries, but it's just that they require more funding. The first one is health belief model. The second one is a trans theoretical model. And the third one is social cognitive theory. So it's from practitioner to study all these theories and models, to adapt it to the environmental people in the community, looking at their behavior. How can you modify their behavior, having studied that pattern of behavior, so that the health change you are interested in can be bring about and people can live a healthy life. So, this slide is, next slide. This is health belief model, but the prints are small. So people in the community can look at a disease condition. Concept is about 6 of them. What is their perceived susceptibility? What is their perceived severity of the ailment? You as an healthcare professional may be looking at it that this is a very serious matter, but the community may look at it, what's the big deal? What's the big deal about it? People have been dying of this thing. The blood come out of people's mouth when they die. Meanwhile, it may be a Lassa fever case. So when you are now trying to use a body bag, put chlorine inside the bag, you use a personal protective equipment, people in the community will look at you, these people, why are they making it look as if people should not die? What's the big deal about it? We can go and bath for him at home. You can't touch him. No. So it requires understanding that people, the background where they are coming from, they don't understand what you know about the ailment. So you have to come down to the level and bring them up to your own level of understanding. What are the perceived benefits? What they stand to gain if they understand you and follow what you are telling them to do in terms of health behavior and health practices? What are the perceived barriers? What are the keys to action and self-efficacy? These are things, the concept of health belief model. Believe about, the first one is susceptibility, believe about the chance of getting a condition. You look at what people think about acquiring or getting that. Let's use Lassa fever. Individually, people say Lassa fever, well, is not in our community. Those who are dying are just people that are offended God. Well, we know that is due to mastomyces natalensis, something like that. It's a rat with multiple mammary glands, about 16 or 8 to 16 mammary glands. They are different from conventional rats. Actually not found at home. They are found in the bushes. But when farmers are clearing the bushes, burning them, they run away from fire. And that's when they enter the houses. Their urine is what is causing the problem. They urinate under any food that is opened, any water that is opened, anything cooked that is open. And once you take it, it's likely one comes down with the disease. Now, you need to understand what are the beliefs of people in such community about them having such an ailment. They may not believe in the rat being an agent of transmission of the disease. So there is need to even start from there. That, okay, can we clear the bush instead of burning it? Because that may be another way to prevent rats from running to the buildings. If you clear, they won't run away from fire. And then you save the houses from coming in contact with those rats that transmit Lassa fever. Then also, why people need to cover their food, cover their water, and not expose their grains outside for sun on the ground where rats can actually reach. Severity, believe about the seriousness of the condition and its consequences. People may tell that, 100 of us have been living here for the past 20 years. Only one person died and you want to shut down the community. This is not a big deal. It's just that he died of old age. So they may have, it's possible people have herd immunity. And I can tell you for sure that it does happen, but for herd immunity, some people would have died. About 5 years ago, in our department, we were exposed to Lassa fever. Before we get to know that a body had Lassa fever, the autopsy has started. In fact, the autopsy was concluded. Now, the irony of the fact is that those who conducted the autopsy, they didn't come down with any Lassa fever. They didn't come down with any infection. They came from Jos. They were 2 residents from Jos, where the Lassa fever is actually a bit higher than what you have in Lagos. So it's likely that they've been exposed to people that had Lassa fever with minimal exposure, and they develop immunity from what we call herd immunity in that community. And they didn't come down with a severe ailment that can result in death because of the titer of amount of antigen they were exposed to. Now, they interacted, they called the resident who is a Lagosian to come, who is not in the autopsy, to come and show them how to dissect an organ. The person went, just showed them, and came back upstairs and interacted with 2 other residents upstairs who never went to see the autopsy. You won't believe it. The 3 residents from Lagos came down with infection, whereas those who were in the autopsy room that did the autopsy, none of them had any form of fever, no headache, no body pain. No, the only thing that was detected in their blood was that they have antibodies to Lassa fever. Whereas the 3 residents that were originally Lagosian were admitted. In fact, they were treated. And if not for that, because all of them have similar ailment, body pain, fever, and symptoms, early symptoms. So this was caught in the nip so that it doesn't progress. Otherwise, it would have been very, very disastrous. So people also need to be aware of this severity. What are the perceived benefits if they avoid the risk? And this will enhance the capacity of people to understand you that if you show them video of those who have problems and those who die from the ailment and those who survive it, it may let the community know the advantages, the benefits of what you are trying them to do, and they may accept it on time. And what are the barriers? Believe about the materials and psychological cost of taking action. So some of these things may require them losing money. You know, you spread the corn beside the road, tarred road. You are not paying for anything, but you now ask them to make a platform where they will still spend money to buy a flat iron shield and spread it on top of it. That will be costly, and they look at it that they are losing money. So these have to be weighed in terms of what are the benefits and these are the costs, and these are things that can serve as barrier to whatever you are telling them all about. Next slide. Talk about trans-theoretical model of change. Next slide. All right, you're there. So it also has several stages. Pre-contemplation, somebody who has no intention of taking any action within the next 6 months. You have interacted with people in the community, and you've categorized people into different areas. Pre-contemplation, contemplation, preparation. Those who are pre-contemplation are those who are not intending to do anything within the next 6 months. They say, no, it's not me. God forbid bad thing. It won't happen to me. I've prayed over it. And that's the new challenges we have in our society. People are ascribing things that science have solved to God. It's God that gave the knowledge, and they won't do anything. People have high blood pressure. Instead of doing what is right, they said they are praying over it. They go and start praying and fasting. So instead of doing anything, or some people say, okay, give me some more time, I will take an action. So those who have intend to take action in the next 6 months, some of them will fall back to pre-contemplation. Some of them will move forward. Or those who are prepared intend to take action within the next 30 days and has taken several behavioral steps in that direction. Those who are ready to accept what you have taken. And those who are half action has changed behavior for less than 6 months, or as maintenance, those who have changed behavior for more than 6 months. So these are things that you can categorize people that you have tried to talk to about an ailment. Or let's talk about diabetes mellitus now. You want to talk to me about diabetes, you know that it has to do with diet, it has to do with exercise, it has to do with people checking their blood sugar and also taking their medication. That's a 4-pronged approach to managing diabetes. And when you talk to people about it, those who have diabetes, you see some people that I can't kill myself. Me, I shouldn't take Coca-Cola. I will take the drug now. So they are not willing to even involve themselves in doing any dietary modification at all. They keep eating whatever they want to eat, and also taking the drugs. So whereas we know that dietary modification can actually do a lot in reducing the mobility emanating from diabetes mellitus. So, and those who are caught, okay, I will stop smoking very soon, but give me some more time, because they are addicted to it. Or those who are not even doing any form of exercise. So these are things that can actually affect the disease progression, number of people that are coming down with an ailment, and outcome of the disease in society. It's not just prescribing. You can be prescribing, but the larger community, if there's no intervention, more patients will be coming to the hospital with the same ailment. Whereas intervention means when you give health education, okay, you don't take excess of anything. You don't take sugar in excess. You don't take carbohydrates in excess. Take some proteins with it. Do a lot of exercise. It will assist you. Check whether you have blood borderline or upper border of blood sugar. You may need to modify your diet. So that is talking to people in the community to reduce the risk of coming down with diabetes. I give another example. In Saudi Arabia and the whole of Middle East, before 1977, less than 25% of the region had diabetes. But after 1977, when the oil boom reached the peak in Nigeria, it was also called Udoji's money. Nigeria also got a lot of lagis during that time. But for Saudi Arabia, UAE, Qatar, they came up red, such that within 10 years, a country with those regions with less than 10% diabetes mellitus, because they were taking their local food before the advent of oil bonuses. But with the oil bonuses expanding the access to fund by 1977 till recent period, in fact, as far back as 10 years ago, a third of Middle East is painted in red in terms of diabetes because of their dietary way of life. Every food is accompanied with Pepsi. They take a lot of sugary drinks. In the morning, in the afternoon, at night, they take rice with Pepsi, chips with Pepsi Cola, high refined diet. And the government, and most men are rounded. They are overweight, they are obese. And they are trying, government has been spending a lot of money in terms of health education, educating the healthcare provider first, and the students, then the larger community, to reverse the trend. So now they are being able to control progression and actually improve in bringing down the percentages slightly lower than the way it was going. Otherwise, more than half of the population would have been diabetic. But that is what government that's supposed to be responsible did when they noticed that they failed in terms of they have to redirect their health policy such that the larger community can understand that this is a threat. It's not that they banned Pepsi Cola, but people are now having dietary modification to what they need to take. And that's one example. Next slide. Social cognitive theory. It also have several concepts. Reciprocal determinism, in which the dynamic interaction of the person, behavior, and environment in which the behavior is performed. And behavioral capability, knowledge, and skill to perform a given behavior. Then expectations, what are the anticipated outcome of a behavior? Like cigarette smoking. You can don't go to a community and tell them don't smoke. People will just listen to you. They say, why? My father smoked and he died at the age of 95 years. My grandfather died at the age of 80 years. So when you say smoking kills, why did they die? I didn't smoke more than them. So, and that's where you really have to listen to people. Don't judge. You have to listen to them. Then you have to show them people that have died. Otherwise, the people that are community leaders may truncate the health education you are giving, because if they are smokers, they won't allow you to say anything. So you have to understand the community very well. And then when you are now entering the community, you have to give a lot of creative examples with vivid pictures so they can see, okay, this is where we're starting from in some communities that have been addicted to smoking in the past, and this is where they are now. So if we're not careful, over a long period of time, we may actually end up at that level. It may not be in your generation. The next generation may suffer from it. Your wife may suffer from it. Your children may suffer from it. And people may actually accept, perchance, next slide, accept that form of. So that's the diagnostic framework of major behavioral theories. The health belief model, the trans-theoretical model, social cognitive theory, just highlighting it, how the target level individual believes, the trans-theoretical model individual stages pre-continental maintenance, and the social cognitive theory interpersonal, and environmental. Next slide. So for professional blueprint, there are core competencies. This actually is taken, most of this is taken from WHO work on research and health education and core competencies in health education. So the U.S. National Commission for Health Credentialing defines the operational boundaries of the profession, and evidence-based practitioners not just disseminate information, they engineer comprehensive community health solutions. So if you sit down in your office and just treating people with diabetes, with hypertension, the work will invariably overwhelm you, such that you may not even have time for yourself again, because more people will be coming down. So the most important thing is that for health policy in every particular society to look at the root cause analysis of what is causing the problem through a funded research to document what are the behavior or what are the risks, what are the attitude of people in the community that is predisposing them to a particular ailment. Can it be modified, behavioral modification, in terms of what they need to do, avoiding the risk and risk behavior, what they need to do in terms of when they see people that are at risk of that ailment, or those who have come down with the ailment, so that it can be nipped at the bud and reduce the number of people that are coming to the hospital or to the clinics, so that the healthcare system will not be stretched beyond limits. And all these things has to be voluntary. So defining the character of health education is the voluntary participation of learners in determining their own health practices. So that's the ultimate game. You want people to own their health. You want them to believe that personally, I want to take charge of this, my health, and whatever information we are being passed, once they understand it, once they inculcate into their behavioral practices, ultimately, the larger percentage of the community may not come down with those health challenges. And government, people in the community will also note things that are putting them at risk, like industrial pollution. They will quickly report to the regulatory agencies. And if the regulatory agencies do their act rightly, then the community will be saved from coming down with ailments emanating from such conditions. Next slide. Life cycle of health intervention. You have to plan, formulate measurable objectives, design logical and targeted intervention. For most things we do in health, particularly if you are now going to intervene, you've gotten to the point that, okay, there's a problem, you've reviewed literature, that problem exists elsewhere, what have they done to curtail the problem? So you have to plan. What is feasible? What is our objectives? What is our goal? And what are the interventions that we are going to do to control that health problem? Then that takes us to implementation. Exhibit competency in executing tailored educational programs. Implementation to stop a problem. There are different levels. You have the primary prevention, secondary, and tertiary. So, and all these has different levels of education. For those who can talk at the level of primary, secondary, and tertiary are different, because that has to be based with their foundation in terms of knowledge. And that will also take us from, after implementing, take us to evaluation. What have we done? So you develop plans to assess achievement of objectives and interpret results. You've gathered results about what you have, intervention you have implemented, and what has been the outcome. So you look at it like, and that you evaluate, have you been able to meet those objectives that you set at the initially when you are planning to intervene in health-related problem in the community, and then to gather health-related data and distinguish behavior that foster or hinder well-being. These are things that it's like a cycle that will assist in planning and implement and evaluate, and this will bring about a complete total health of the community. And this is, next slide. It shows the path to mastery, scaffolding of evidence-based practice. From tier 1, being a novice. When you come into medical school, you come in as a nursing student, you come in as a medical laboratory science student, you come in as a physiotherapy student. They throw you to science. to continue doing physics, chemistry, biology that you did in secondary school. You have no idea that you're going to come across, if you're dental or medical, across a body to dissect. You don't know what it looks like to dissect a body. You have no idea that you're going to touch tooth and remove tooth in a patient. You have no idea that they're going to start trying to do muscle exercise for somebody who's drooling saliva. So most of these things is when you now get to the clinical end from year 2 that you start to come across. That time you are still a novice. You start to build awareness, understand the structure of evidence-based practice, because most of what you are being subjected to are evidence-based practice in the hospital, from pre-clinical to clinical side, formulating basic PICO, patient or problems or population. That's what P stands for. Intervention, I, and comparison. You compare what you have done or what patient has and then the outcome. And these are the questions that try to come across classroom. They give you information. This is what is responsible for this. High blood pressure may invariably lead to cardiovascular arrest. High blood pressure can result in cerebrovascular accident leading to the brain. High blood pressure can result in renal failure, kidney failure that require transplant. Which one is cheaper? Buy a drug that is 5,000 naira per month, 10,000 per month, than to do a renal transplant that is up to 20 million naira per one transplant. So these are things that you are exposed to as a student with information that is evidence-based. So as a novice, you come in with that information and you start to acquire information from your lecturers who are giving you information based on evidence. Then you've got an apprentice, and gradually, those who are exposed to early clinical years, like dentistry students, like physiotherapy students, they start to treat patients early on in their educational career. So application of theory using validated tools to assess pre-processed source of information and interpret. Then you climb the stair further to being a clinical integrator, real-world translation, performing critically appraised topics, cards, while on clinical rotation. So you go through different rotations, they open it to patients, OSP, and then bridging the academic and clinical. They put you on call duty. You be on call. You have call rota. You spend some time with senior registrars in neurosurgery, neurology, cardiology. You are exposed real time to patients. They ask you, what are you going to do while they are treating patients? What are the first steps you are going to do when you see patients with multiple injuries? So as a student, you start to interrogate what decision, because it's not for you to now start going to open your book. Okay, what do I do? Patient would have died. So you're exposed to it real time. And then by the time you climb to stair 4, you're already a practitioner. Continuous engagement, incorporating evidence-based practice to routine care through journal clubs, audit, shared decision making, going for conferences. Because without going for conferences, you won't know whether you are outdated, whether you are left alone. People have left what you are doing, and people are already implementing new things. So that is the advantages of going for conferences. It requires some spending of money, but we hope that our country economy will improve so that people can actually, we can be in tune or in sync with the rest of the world. Next slide. Cultivating the clinical X factor. The evidence, pre-processed data, and guidelines. There are guidelines for treatment of many diseases that have been aggregated based on different literature, meta-analysis, data from retrospective to prospective studies, experimental studies. People have data, and from there they have guidelines as to how to treat patients in their communities. Sometimes we adapt those guidelines to our own community, but also you have to note about patient values, their level of literacy, their shared decision. You can't decide for patients. For instance, in 1950s in US, they were asking everybody for screening to go for chest X-ray, and it was free. People are not going. They were afraid that if you have severe disease, you lose your job. But not knowing that there is treatment for it. So they have to really look at what behavior is making people to run away from the X-ray. And they explain to them, you are not going to lose your job, then people start turning up a little again. So you have to really understand the shared value of the patients You can't decide for people. It must be at the level of the community. The community must accept any form of intervention you're bringing to them. Otherwise, you are wasting your time. You won't be able to intervene. Then, social determination, psychological theories that we have mentioned earlier on, environmental policies. Sometimes some of these environmental policies come from government. You see, when it rains in Lagos, people throw their waste into the running water, and then it blocks the canal. A living example is front of Lute Gate. If it rains for 1 hour, the frontage of Lute Gate will not be passable in Lagos here, because people have poured waste into this. There's need for environmental policy from government and behavioral changes on the part of individual and people. Then you talk of pathophysiology of diseases, which as a medical student, as a nursing student, as a physiotherapy student, you have to, medical laboratory science, you have to be exposed to from year 2, year 3, year 4. You have to understand what is responsible for A, what is responsible for B, C, and all form of ailment that we battle with in our environment. So that once you know those ones, what are the things causing them, what are the risk factors, then one by one as a student, you get to grasp, because these are things that you are being evaluated on. Do you know the risk factor to breast cancer? Know the risk factor to lung cancer? Know risk factor to hypertension? Risk factor to diabetes mellitus? These are things that you'll be evaluated upon. What are the clinical features? How do they present? How does it distort or disturb the normal physiology? This is what you are taught, and this is what you are being evaluated upon. How do we now intervene? So the concept is to integrate all of this together as a practitioner by the time you are graduating, and putting it together holistically to engage the community or individual to modify their behavior to engender a total health activity that will bring about improvement in the health of the nation. And the practitioner mandate, last slide. Everyone in training should be in the game of improving healthcare. It's not just saying, I want to do some evidence-based practice. It's ultimately about improving healthcare. You empower, build individual capacity and health literacy, both as an health practitioner. You can't be telling people to stop smoking and you are smoking in front of your patients or smoking publicly. You have to apply, utilize rigorous evidence-based practice and behavioral theories, and transform, shift the environment through policy, advocacy, and continuous assessment. This last part is what majority of us that are healthcare providers shy away from. Advocacy. The power of advocacy is very strong. Majority of healthcare providers are not involved in this advocacy issue. You don't see us talking on television. You don't see us talking on radio. You don't see us talking to communities. We find it difficult to lobby government for things that will be beneficial to the entire country. Everybody is comfortable sitting down in the corner. We have different health societies, NMA, Nursing Association. How many have you seen all this dropping a policy that will impact positively on the populace at National Assembly for them for consideration? No, you won't see a bill emanating. In fact, I can't remember a bill from any of these organizations, associations, to enhance the health being of the entire country or community based on the health challenges we have. Rather, we write anecdotes. But those are things that advocacy is very, very important, because the policy that will be driven, that will drive this disease out of the community, is going to be made by the National Assembly. They understand very little about what we are talking about. You have to lobby them. You have to advocate how they can make policies that will improve the health of the country. And these are the references that I use for this presentation. Thank you for the opportunity given. And if there are questions, I'm open to engaging those who have questions.
Thank you. Thank you so much, Professor Badmos, for that very insightful session. Who is that? Mujib, please mute yourself. Thank you so much, Professor Badmos, for that insightful session. We appreciate your time and the knowledge you have shared with us today. Scholars, I'm sure you found this session valuable. But before we move into the Q&A session, I'd like to hear from a few of you. Take away from this session. What's one point from today's session that has changed the way you think about research evidence or health education? You can unmute yourself to speak. if you want to. Kufre, do you want to say something? What's one takeaway from this session?
Yes, ma. Good evening, everyone.
Good evening. Yes.
Yes.
Can you
Thank
share
you so
one
much,
thing
Prof.
you've learned?
Yes. Yes. I've learned a lot in today's session because I know now that evidence-based research is for everyone, especially for those going into health sector. And times and again, we see, as Prof said, what people think and what we, the healthcare, maybe medical students or the healthcare professional, are thinking are different. How are we going to like hear from them, or how are we going to align so that it will also be in the same level as that of our own? So it comes for curiosity, trying to bring their own level to our own so that they can hear. And then before we go to any research, we have to make sure to see whether these things have been done before in terms of literature review, and then we come to method we can use to arrive at the conclusion so that it will bring the kind of results that we want. Because if we don't do this, it might not bring the result, and then maybe we can end up doing another thing. I can remember the time I was trying to do one of the research, and I see that when the person that wanted to sacrifice the animal for the research is supposed to have weighed the animal, but he not do that. And then I didn't even know that he's supposed to have done that. So when we came to know about this, and it was too late. So and now we see that that research cannot follow through. So I really learned from here. So whatever we are going to do, we sit down and calculate and do everything. From there we can do it. So this session is very impactful. I really appreciate it. Thank you.
Thank you. Very good point, Kufre. Thank you. Does anyone else want to talk? Toyiba, do you want to share your takeaway from today's session? Is someone talking? Okay, Caleb, you want to talk? Can go ahead.
Good evening, everyone. Good evening, ma. Thank you for this life-changing opportunity. The session is actually impactful. And one striking thing I've actually learned with respect to this session is that beyond healthcare,
You are
beyond
using
administration
bedroom
of drugs.
voice. Or is it me?
Oh yeah, I also thought it was
Sorry,
my
I think
audio.
it's the network.
Yeah.
Please, are you hearing?
Can Mujib please
Hello,
mute
ma.
himself? It keeps interfering. Caleb, yeah, please just
Hello.
increase your voice. Be more audible,
Okay.
please.
Good evening,
Thank you.
everyone. Good evening, ma. Good evening. Good evening, ma.
Good
The
evening. We can
session
hear
is
you.
actually very, very okay. Thank you very much. The session is very, very impactful, and I've learned something striking. Okay, so later on, when we actually become medical professionals, that treatment of patients won't just be based on administration of drugs, but also checking the person's socioeconomic level, dietary level, if the person smokes, and if the person takes alcohol. So beyond administration of drugs, there are other things you should also check out for to enabling proper health function of the human. Thank you very much.
Thank you very much for sharing, Caleb.
Thank you. Thank
Okay.
you.
Does anyone have questions to ask? You can unmute yourself to ask or type it in the chat. Is that Mujib? Any questions? Okay. Okay. I think we can move to remarks from Professor Abdul Karima. Please share your remarks with us now. The floor is yours.
Okay. Thank you very much, Professor Badmos, for the very enlightening lecture. And their scholars. The only thing I want to say in simple language is that as health professionals, we must have inquisitive minds to solve societal health problems. And, that's what research is about. If your patient keep coming and they keep, all you do is just prescribe drugs and you're not bothered about, why is it that they are not improving. You're not bothered about, okay, you've been doing certain procedure the same way for several years, and you have not queried that procedure, whether it has worked or not. You tell people to wear a mask, to wear gloves and all of that, and you have not questioned or evaluated whether or not those procedures are actually preventing infections, So you will not be doing so much good, because it will get to a point where you will be uninterested again, because nothing really will motivate you. But when you have inquisitive mind, you query every action. If you have been doing any procedure for so number of years, you want to question it to see how has it fared. Okay? So this lecture is about, it's not because, because of your final year research and so on, but it's so that every now and then we should be engaged in critical thinking. How can we improve status quo? How can we provide evidence? If you have noticed one thing or the other during your encounter with patients on the ward or in the clinic, you want to question it. What can you do? What research question can you ask for you to be able to provide evidence to effect change that will result in improved health for the populace? So wherever we are, at whatever stage that we are, we should always be thinking of how do we improve? What can we do? What research question can we interrogate? And then you will also be contributing to improving the health of the populace. So essentially, the session says research, evidence, and health education. So in essence, what we are saying is engage in critical thinking at every point in time. Ask research questions, and then from asking research questions, you provide evidence. And once you have the evidence, you use it to effect positive change through health education of the community. And it doesn't have to start big. It can start small. And from small, from being a novice, you become an expert researcher. So I want to thank Professor Badmos again for the enlightening talk. And I do hope that, some of you will have begun to, put out some research question that you want to, work on later when you have the opportunity. So thank you very much. And thank you, Mariam. Over.
Thank you. Thank you very much, Ma. I think we've come to the end of today's session. Professor Badmos, on behalf of FAJIM Medicare Foundation, our founder, and all of the scholars that are present on the call today, thank you sincerely for taking the time to mentor us. We appreciate it. Scholars, I hope you have filled the attendance form. Just before you leave, We hope that this session has encouraged you to think critically about research, evidence, and health education as you progress in your journey as healthcare professionals. And just like Prof said, as healthcare students, how you interpret evidence and communicate the information responsibly has the power to create meaningful and positive change. Okay, thank you all once again for joining. Have a wonderful evening and a productive week ahead. Thank you.